Welcome back. The next session is entitled Management of Viral Hepatitis, where we're going to be looking at hepatitis C related disease and other issues. And the first speaker is Sabine Nzeyimana from the Rwanda Biomedical Center, who's going to present on hepatitis C elimination in Africa, the current situation in the time of DAAs. Sabine is the Director General of Rwanda Biomedical Center, serves as a fellow at the African Scientific Institute, and is also a fellow of the Royal College of Physicians here in the UK in the Edinburgh branch. She's really an expert in epidemiology and research methodology in hepatitis C and indeed other subjects, and it's a great pleasure to welcome you here today, Sabine.
Thank you, and welcome to this presentation on hepatitis C elimination in Africa, the current situation in the time of DAAs. My name is Sabine Nzeyimana. I'm from Rwanda, and I'll be presenting some experience from Africa, but also the case of Rwanda and how we established a control program, how we started screening people, treat and cure, and how we went through the journey of elimination of hepatitis C. And we are about to achieve through partnership, coordination, leadership, and other factors that I'll be presenting over the next 15 minutes. Again, welcome to this presentation. The global burden of hepatitis C is actually a new challenge for many countries. We've been used to control HIV, malaria, and tuberculosis over the past 2 decades and more. But what we are seeing here on this presentation is actually that in the past 5 years, we've been seeing hepatitis C becoming a new challenge, actually taking over in terms of death we're recording in different countries, and not only in Africa, but the global context has changed with HIV, tuberculosis, and malaria actually being controlled, a few people dying from these diseases. But hepatitis C is taking a lot of lives, as you can see, and is likely to continue if nothing is done. But I know many countries are doing something to change this trend and this situation. It is also estimated that 5% of Africans live with hepatitis C actually being infected. This is estimated to be about 32 million of people, and is one of the highest prevalence in the world. Other countries, other continents are also affected, but differently. These are not the latest data, because it's not even easy to get these informations. But what are we doing to change these situations? From the global context, by establishing national strategic plans, by working on the pharmaceutical industries, what are the drugs available, diagnostics, and what are countries committing in terms of money, leadership, and systems to change this situation. The World Health Organization has been delivering key documents and guidance over the years. Every year, there's something that is produced, but how are we moving from documents into implementation, into changing lives? This is a responsibility of everyone. So the latest document, I think one of the most important document that was published in 2016 by the World Health Organization, is the strategy to eliminate hepatitis C as a public health threat by 2030. How are we aligned to achieve this goal that seemed impossible, sometimes ambitious, but if you think about the lives lost, is actually not ambitious at all. It's doable if we commit to do it. And we'll see the examples on how it's not an impossible mission. It's actually something we could have done some years back. We have limited data in terms of understanding this epidemic, this pandemic actually. I'll call it silent killer that has been going through generations. And now it's our responsibility to stop it in the context of other diseases, like the current COVID pandemic. HIV is still there, malaria as well, tuberculosis, maternal child health. So we have so many challenges, but hepatitis C should be seen as a priority for elimination and without pushing it for years to come. So if we look at the incidence and how we can reduce it, we had committed to reduce the incidence by 30% by 2020, which is this year, but also new infections by 80% by 2030. That is 10 years to come. It's not far. It's just a matter of what are we doing to achieve. If we wait, then 2030 also reach us. I remember when we started this 5 years ago, I think 2020 will be really far, but it's now. So again, 2030 is not far. We also committed to reduce mortality related to to hepatitis C by 10% by 2020 and 65% by 2030. Where are we now? We also committed to reduce increase of sterile needle and syringes provided by most at-risk people, those who are injecting the drugs, were actually most at risk to acquire this virus. 200 by 2020 and 300 by 2030. We had also targets for testing. Of course, you can't treat or cure those who are not tested, which is the entry point for knowing who has the disease and stop it. Committed to achieve 90% of people who will be diagnosed, know their status, aware that they have hepatitis C infection by 2030. And 80% of these will be treated. So again, to eliminate hepatitis C as a public health threat, 90% remains in our minds, diagnosed, and 80% treated. There are some countries that are doing well, but look at the numbers. The list is just so small that we can't achieve these global targets if we have only 3 countries on this list. And I will tell you what we are doing as Rwanda in the context of the continent that is most affected by many diseases, including hepatitis C. So in Rwanda, in 2018, the government established an elimination plan to be achieved by 2023. The plan was simply to screen 4 million people, aged 15 years and above, are most at risk for hepatitis C. And if we screen 4 million, expect to treat 110,000, which is 90% of the targeted populations. And by doing so, we'll reduce the prevalence of hepatitis C in Rwanda from 4 to 1.2%, which is an average of 22,000 people treated every year. And if we do so, we would reduce the mortality related to hepatitis C with an investment of $43 million. So when we launched this, some questions came out. How much money do we have to implement? Do you have systems? Do you have leadership? Do you have policy? Well, how are you going to achieve this? But the lesson we've learned over the years by controlling other diseases, well, you don't need money to start. You need just commitment and believing that you can do it. You need guidelines, you need policy, you need coordination first, then money, then the how will come after. We've learned that with $1, you can start a program. This is what we did with hepatitis C. And I'll tell you, and I'll show you the progress, what we've done, what we've achieved. Of course, we still have a lot to do. It was not an easy journey at all. So how did we start this program? How did we also think about elimination of this disease that was not funded as HIV, as malaria, as hepatitis? The first thing was, how do we find the cases? Who has this virus? Started with community sensitization and screening campaigns. I remember in 2017, when we did the first screening, we expecting 200 people on a stadium in southern province. When we went to screen, we end up by finding actually there were 4,000 people who came, and our surprise was, oh, people do really know that this virus exists, and then they're actually coming to be tested and know how and get treated. We had to screen all of them the same day, but it wasn't easy. We had to call upon on different doctors, nurses all around to make sure from 200 plans to 4,000 expectations and reality. So we don't lose the trust between our community and the new program we're establishing. With that, we realized that actually we not achieve this by using pathologists, specialists in internal medicine, those who have been handling hepatitis over the years with interferon, with ribavirin. So we had to think about task shifting decentralization from those doctors to the nurses and now to the community health workers. We had also to talk to producers of this medicine. And I'll mention about the cost of the drugs that were complicating our situation, from $86,000 for one patient who had hepatitis C to be cured. And think how a country that just recovered 2 decades ago from genocide that took over 1 million of people, and how we're going to treat all these people who are in need. And we don't have medicine, we have patients. How do we link these two? By talking to pharmaceutical industries, by explaining our case, by showing how we're willing to start a program. Has worked with partnerships with different people who have been helping us to negotiate and to move forward, even without resources to start. So everyone needs to see that you're working. You need data, you need strong M&E that will give information that needed for planning and to show that it works. There's one country that is trying hardly, but there are some other countries who had already started. So in simple ways, we tried to show the journey we went through from 2014 by the first clinical guidelines with DAAs. We even had the medicine here, but we needed the medicine to come when we have policies and documents and guidelines and systems in place. Then we started the screening I was talking about. We started with campaigns in high-risk groups, by age, by districts. At the same time, we're collecting data and information on how we are going to be moving it in phases as we get funding, as we get people ready, and so many partners joined us throughout this journey. Until now, we're actually close to the elimination. I will show you some statistics. So in simple ways, by working stepwise, targeting high burden populations with strong political willing, and also investment from domestic resources. There's one example I actually want to highlight, that when we started getting domestic support, so many partners, banks, private sector organizations, church leaders who came out and say, yeah, we need also to save lives by contributing to this plan. There's one example that will probably surprise you. So the Rwanda Revenue Authority was one of the first contributor to this elimination plan. Some people asked how Rwanda Revenue Authority was the first to give money. This as an institution usually that collects money from taxes and then can fund other projects. But the great answer that the leaders of Rwanda Revenue Authority provided were, actually, we need health people that will provide more taxes, we contribute to the economy. If we invest now, it's for us, for the economy of the country. we need the wealthy, we need the healthy people so that they can actually return or give back to the economies, the countries. So this domestic support and understanding and buying and ownership has helped. And we didn't create a vertical program because we knew it would cost us billions. But the first thing the government did was to make sure HIV program and the hepatitis program are hosted together. Almost the same virus with no vaccine. And so if you provide antiretrovirals, same people can provide DAAs as well. If you do a training for HIV for 5 days, you can maybe save 1 day and you train for hepatitis as well. Because at the hospital level, at the point of care, these are the same people. So actually, sometimes hepatitis C was seen as benefiting from HIV resources indirectly and directly, and it worked. So I can't forget the strong external and domestic partnership that supported in reducing prices, in negotiating and packaging the proper plans and submissions. And until now, they're with us. We really appreciate it. So this slide is really so complex, but I did it intentionally to show you how, in the beginning, just the path, the flow of a patient was so complicated. From patient home to the health center, then to general practitioner, to see a specialist, then to the lab, then to access the DAAs. There were actually more than 16 steps that a patient could do to get a test, get a result, to get medicine, to do the first visit, the second visit, viral load. So it was so complex, and I leave it to see how, even if you're a patient, probably your virus won't be nice with you if you have to go through all these channels. So we made it simple, like this. What if the patient leaves home and goes to the health center and returns back home from 17 steps to just 4 steps? To achieve this, you just make some simplifications. There's someone with a virus, you can have rapid diagnostic systems and return of results, and medicine can come up to the health center without 2 or 5 specialists who will come down maybe a month for a visit. We went through all these challenges, but learning from the challenges and fixing it, and patient-centered approach worked. Now, where are we? This slide summarizes where we are. Our target, as you remember, we had to screen 4 million people. We have so far screened 3,900,000, almost achieving all we had to screen. And of this, 25,000 people have been treated and cured for hepatitis C virus. So the prevalence has reduced from 4.1 to 1.8 so far. And the cost of diagnostics also reduced. Actually, before it was more than $15. Now it's 0.7. The cost viral load also reduced from $22 to just $9, as well as the cost of treatment. In the beginning was $86,000. In Rwanda, we accessed it through the a negotiation with manufacturers from $1,000. Now it's at $60 for an entire cure rate. And these are the medicine we've been using over time: sofosbuvir, the dipasvir, and now sofosbuvir and the cladribine. And we've seen a success rate that is interesting over the years. And so many people and the community feedback has been really, really interesting. So these are national statistics, but you will see differences according to district. In the south part, there are districts who are highly affected by hepatitis C. Actually, in the north, some districts And the differences in terms of district is actually raising a lot of questions. And we've seen the same statistics in neighboring countries where, for example, in the South, if you talk to colleagues in other health system in those countries, they will say the same. We're seeing actually in the North some increase in cases. What you see here, if you talk to neighboring countries, here we have Uganda, Burundi, Tanzania, and Democratic Republic of Congo. So this shows how this virus has been moving from countries to the other and has no limit. And it affects the continent, it affects the entire globe differently. So why do we have this level of analysis, this granular review of data? Because the intervention will be different. What you do here will be different from what you do here. And having data in real time for analysis for decision making is key to eliminate hepatitis C. Now, I've mentioned that when you have a new program, you don't need to build a new system, a new structure, because it is costly. And this is how our system has helped to package and to add on other programs in the other system. The stronger your health system, the stronger your new programs, and the better you'll be prepared for any other diseases, including the current COVID pandemic. So our basis, our strength is here at the community level. And we have people we call the heroes of health sector in Rwanda, the community health workers. They're about 60,000. In each village, they're about 3 to 4. They can treat malaria up to 70%. Actually, 70% of malaria cases in Rwanda are treated at the community level by community health workers. They're supported by health posts that have some additional health services, health centers, district hospitals, provincial, and referral hospitals. What we did in hepatitis context, we brought the services and simplified the system so that you don't need people coming from the community to come up here to the referral system to get medicine, to rather receive it here, and probably here, but not upper levels. There are so many other diseases that are managed here, and you want people to go back home and do their daily business. So I would like to pause here and thank you for your attention and the invitation to be part of this conference. Thank you.
Thank you, Sabine. That was really great. I'd now like to move on to the next speaker, who's Nicholas Luhmann from the World Health Organization in Switzerland, and he's going to present on the inclusion of vulnerable groups in hepatitis C prevention, testing and treatment in the African region. Nicholas is a technical officer at the WHO headquarters, focusing on viral hepatitis prevention, testing and priority, and has been working on this subject for over 10 years. Nicholas.
Good afternoon, good morning, dear colleagues in the African region and around the world. I am very pleased to present today in the COLDA 2020, the virtual conference on liver disease in Africa. And I'm very pleased to present to you on the question of the inclusion of vulnerable groups in hepatitis C prevention, testing and treatment. On the picture, you can see this is a small photo of a visit that we did earlier this year, because before we were all locked down and not able to travel anymore, in Cape Town with colleagues from different countries in the African region to a drop-in center for most affected populations and injecting drug users and people who use drugs in Cape Town in South Africa. I have no conflict of interest to declare. Here's my short outline for today. I will start with some thoughts on the epidemiology of hepatitis C, and more specifically with regards to the African region and vulnerable groups, and then link that to the global health sector strategy and specific aspects of tackling the epidemic in most affected populations. And then conclude with some thoughts around the implications of this talk. So to start with, let me talk a little bit about hepatitis C epidemiology on the African continent and in vulnerable groups. First of all, you all will know that in 2015, WHO has estimated, together with the Center for Data Analysis, CDA, that 71 million chronic infections of hepatitis C are estimated globally, and the African region is home to around 12 million, similar to the Southeast Asian regions. Those estimates are currently updated. This is an interesting slide that takes this same data set and presents it in a different way. I've taken this slide from Yvan Hutin, who was working with the Global Hepatitis Program until earlier this year. And he has looked into the epidemic profiles of many of those 110, or of those 110 countries. On the x-axis, you can see to the very left, the countries with a prevalence of under 1%, and then 1 to 2, 2 to 3, 3 to 4, 4 to 5, and above 5%. And what this slide shows is that actually globally most prevalent infections are in countries with a prevalence that is below 2%. There are certain countries such as Egypt and Pakistan and others that have a very high burden and high prevalence rates, but most of the countries have actually an epidemiology of a prevalence below 2%. And most of the African countries will be as well in this group. Why is this important? Is because the testing and treatment strategy in countries with lowish or medium high prevalence rates will be different and will be focused on more integrated approaches and more focused testing approaches, especially in the beginning when compared to those countries with very high prevalence rates, where a more disease-specific approach can be justified and the most efficient. I wanted to share as well this data that shows the co-infection rates for hepatitis B and hepatitis C. So globally, it's estimated that 2.7 million people live with HIV and hepatitis B surface antigen, and that 2.3 million people live with HIV and hepatitis C antibodies. Africa is home to an estimated 19% of the global burden of hepatitis C co-infection, as estimated in this publication by Lucy Platt et al. In Lancet Infectious Disease in 2016. And the absolute number of those co-infected people in the African region is estimated at around 430,000 people. So there is an important part of the global co-infection are actually in the African region, and even more importantly, so for hepatitis B. If we look, for example, here at the example of Burkina Faso and the hepatitis C epidemic in this country in West Africa, and this is not untypical for many of the other African countries. Burkina Faso is a very high prevalent country for hepatitis B and hepatitis C. You can see on the left, on the upper graph, that in women, and then on the lower graph in men, the prevalence. So we can see that it tends to be higher in men in all age groups, that it is increasing over time in people of higher age. And on the right, we can see as well that there is a strong variation by geographical areas in this country. So we can see similar both cohort effects and geographical diversity in many other countries, including Cameroon and other high burden countries in the African region. I wanted to as well show the incidence estimates for the Afro region. Here, 310,000 new infections estimated by CDA in 2015 among the 1.7 million global new infections annually. Another data set from Bristol University estimates similar global data and quite similar data for the African region. So this gives a good orientation on how many new infections we are still seeing in the African region. This is new data that was first presented in AIDS 2020 virtual and by our collaborator Jeff Jin from the Kirby Institute in Australia. We commissioned a global systematic review of hepatitis C prevalence and incidence in men who have sex with men, high-risk men by WHO region. And what we have found is that it has, as it has been described already before, and as you can see here in yellow, that is, we included 146 studies and estimated that the global hepatitis C prevalence in MSM is 3.3%. This estimate was 5.8% for the African WHO region. And in red, you can see that this rate was higher globally and in the African region for MSM, who are as well HIV positive, and there's confirmed results from earlier studies that were not global, but coming from high-income countries, for example. So a population with quite a high prevalence rate, and especially among men who live with HIV as well. Here you can see the data for people who inject drugs for African countries where data exists and that we were able to include. You can see the sources on the right bottom. So this shows in orange hepatitis C viremic infection prevalence rates estimated in this population, and in blue in the general population for hepatitis C, and then in pink the prevalence of HIV infection among PWID, and in green in the general population. You can see here that with the exception of Kenya and Madagascar, maybe that hepatitis C prevalence is higher than HIV in most African countries among people who inject drugs. Unlike for HIV and hepatitis C, where in the general population, where really HIV rates are very often higher than hepatitis C rates in those countries. This shows as well even more so the important interlinkage between hepatitis C and injecting drug use. This is the estimated proportional attributable fraction of new hepatitis C infections due to injecting drug use, modeled by Bristol University for some African countries. Or said differently, this shows the proportion of new infections that are estimated to come from injecting drug use. So you can see here for some of those countries in the African region that, for example, in Mauritius, a big part of the epidemiology is driven and the new infections are coming from injecting drug use for hepatitis C. And those countries like Tanzania, Kenya, and Mozambique, who have big drug user populations as well and are big countries, 20 to 30% of the new infections are estimated to come from injecting drug use. So another hint of showing, or another data set of showing the important interlinkage between Hep C and injecting drug use. So what we have seen in terms of most affected populations and priority populations is really that those include those very stigmatized and vulnerable populations such as MSM and people who inject drugs, but they may include as well people in rural areas or very highly affected sub-regional areas, and people who live with HIV, for example. So how is that taken up and reflected in the global health sector strategy? You know that the global health sector strategy has given very ambitious targets for reducing incidence by 90% in orange on the left graph for hepatitis B and C, and 65% in black for mortality between 2015 and 2030. But I wanted to mention as well the key 2020 fast-track targets for HIV that are the 90-90-90 targets, and that have the ambition to really reduce very strongly the incidence of HIV globally, and are instrumental to controlling HIV, because those two targets and strategies should not be seen as completely separate or in silos, and have very important overlaps. What are the core interventions that would make the biggest impact and allow to meet those targets? For hepatitis C prevention, that is blood and injection safety and harm reduction. And then there is the diagnosis and treatment core intervention for hepatitis B and hepatitis C that is instrumental as well for meeting hepatitis elimination. So where are we in terms of progress? Here, the bottom line for safe injection in healthcare facilities is that globally we're practically on track, and that the African region for this is performing very well and has very low rates of unsafe injections. In terms of harm reduction, the picture is different. Globally, we see a very important gap of this prevention interventions for people who inject drugs. And this is similar in the African region. In blue, you can see the targets or the coverage rates for needle and syringe distributed per PWD per year, which is the core intervention target of the global health sector strategy, and as well an important intervention for HIV, and in red the coverage rates for opiate substitution therapy. We've seen in this area emerging champions such as Kenya, and since a longer time Mauritius, with quite strong response and coverage rates, and emerging countries that implement more and more those interventions, such as Mozambique and Nigeria. But overall, coverage rates remain rather low or medium range. Another very important area with a gap is really the cascade of care for hepatitis C infections. You can see here in the left the global number of estimated infected individuals, 71 million, and you can see there's a big gap. Only very few people know their status, and even less are on treatment or cured. Here again, we have seen emerging champions such as Rwanda or Egypt or Mongolia and Georgia. But overall, on a global level and in the African region, the gap of diagnosis and treatment remains really very important, and there needs to be very clear improvements in this area. So a couple of thoughts how those key prevention and treatment gaps could be closed, especially with a focus to most affected populations, as this is the topic of my talk. First of all, I wanted to come back to this rather fundamental slide or graph on the right, which is what are the essential ingredients of a good national plan. And as we have seen, many more countries are now having national plans for hepatitis. But to really make a big step towards elimination, national plans need really some core ingredients, and this is they need to identify the most impactful and essential services. They need to establish and describe a health information system that measures progress and allows for monitoring, and they need to address the question of the equity and the most affected populations and population coverage, as I have mentioned already, and ideally it needs to be costed and financed. If all that is met, then their national plans provide really the core backbone of progress towards elimination, and they really do need to include all those aspects. Secondly, especially for those countries with, let's say, a 1% or 2% epidemiology of the disease, so in terms of prevalence for hepatitis C, the UHC Universal Healthcare Coverage Framework provides really a very important framework. And so we can see here that this framework has three dimensions. One is the population dimension, who is covered. the service dimension in purple, which services are covered, and then in green, the financial dimension, which describes which proportion of the costs is covered by the system. And this framework really provides a basis to look into how can we best integrate and extend the services that are needed to those in need and extend the services that are available. So in terms of the yellow axis, it is really important to extend the services that are starting to emerge in terms of viral hepatitis response to those most affected and those most vulnerable, but as well to develop the services in an integrated manner and include them more and more in primary health care and, for example, HIV programs. As I have shown, there's quite a strong overlap in terms of epidemic and approaches. The third thing that I wanted to share, or the third aspect that I wanted to share, is quite a fundamental of our recommendations, which are the testing recommendations in view of treatment. And so why I'm showing this, because it comes back to one of the slides that I've shown in terms of lower or higher epidemic scenarios, and as well the data from Burkina Faso. So if we go on the right graph to the middle part, if there's really a country with a prevalence that's above 2%, this may justify a general population testing approach. But many of the countries that have prevalence below 2% or even below 1% will possibly need a mixed approach between very focused testing in most affected populations, and some of those are listed here from the guidelines on the left in white, mixed with focused testing in adults and adolescents and children with clinical suspicion, and where appropriate as well, consider birth cohort testing, meaning testing or rolling out testing to people of older age, because they might have been more affected. In conclusion, I hope I was able to show that many countries in the African region have epidemics with overall prevalence rates that are below 2% and sometimes below 1%. The data that we see is generally quite weak and needs improvement. I try to show as well that populations that have higher rates of hepatitis C infection include, in many countries in the region, people above 30 to 40 years of age, HIV infected people, and as well very stigmatized populations such as MSM and people who inject drugs. In terms of prevention gap, the most important gap lies with access to harm reduction and drug dependency treatment, and this would be an area of important improvement to continue to reduce the rate of new infections, given as well that in the region the coverage of safe injection practices in healthcare facilities is very good. In terms of increasing access to testing and treatment and reducing really mortality over time, this will need to build on synergies with HIV programming and primary health care as well, because for many of the countries, a completely disease-specific approach will not be affordable and relevant. I thank you very much for joining today. You can contact the team on the address provided and the website on the link provided here on this slide. Have a great day.
Thank you, Nicholas. That was, again, a fantastic presentation. We're now going to move on to a live panel discussion, and you will have to access Zoom for this. To do this, just click on the Zoom link on the right-hand side of the page under session information. And the two speakers in this session will be joined by Zaid Houghton from Mauritius, and I'm sure we're going to have a really great discussion.